Cranial nerve palsies. Coming to the first cranial nerve palsy that we are going to talk about, we are going to read about third, fourth and sixth nerve, which is very important. So oculomotor third nerve palsy, the first is anatomy. The course of the nerve from the midbrain to the muscles is divided into following parts. First is nucleus. Nuclear complex is located in the midbrain at the level of superior colliculi. The fourth nerve is located at the level of inferior colliculi, whereas the third nerve is located at the level of superior colliculi. It is both unpaired and paired subnuclei. Unpaired is for both the LPS. Paired is one is superior rectus subnucleus, controls the contralateral superior rectus. That is one important key feature which we tend to miss. It's contralateral superior rectus, whereas the other paired nucleus are all for the same side, which is middle rectus, inferior oblique, which controls the ipsilateral muscles. So the next is Edinger-Westphal nucleus, supplies the parasympathetic input to the sphincter pupillae and the ciliary muscle. So this is one important thing which you should know about oculomotor nerve. Then comes the fasciculus. The fibers pass through the red nucleus and the middle aspect of the cerebral peduncle. So there are these structures, red nucleus, cerebral peduncle, all these things which can cause syndromes. Lesions of the fasciculus leads to Weber syndrome. Weber syndrome involves fasciculus as it passes through the cerebral peduncle and is characterized by ipsilateral third nerve palsy and contralateral hemiparesis. That is Weber syndrome. Whereas the Bendix involves fasciculus as it passes through the red nucleus and is characterized by ipsilateral third nerve palsy and contralateral extrapyramidal symptoms are signs such as hemitremor. So this is Weber's Bendix. Then comes Claude. Claude is nothing but Bendix plus Nothnagel. C++. C is Bendix plus Nothnagel. So what is Nothnagel? Nothnagel involves fasciculus and the superior cerebellar peduncle and is characterized by ipsilateral third nerve palsy and cerebellar ataxia. So these are the four syndromes of the fasciculus of the third nerve. So the next part is basilar part. It starts as a series of rootlets which join to form trunk which traverses the subarachnoid space unaccompanied by cranial nerves. So isolated third nerve palsy is usually basilar in origin. That's, as you can see there, it's freely floating without any cranial nerves and only posterior communicating artery is nearby. So what happens is posterior communicating artery aneurysm can compress the third nerve and it's here. So isolated third nerve is basilar in origin. So intracavernous, the nerve enters the cavernous sinus and lies in the lateral wall of above the fourth nerve. In the anterior part of the cavernous sinus, the nerve divides into superior and inferior division, as you can see in this picture. So it divides into both the divisions after traversing the cavernous sinus, where it enters the orbit through the superior orbital fissure. Intraorbital part, the superior division supplies the levator and superior rectus, whereas the inferior division supplies all the other muscles, which is medial, inferior recti, inferior oblique, all these parts. It contains parasympathetic fibers to sphincter pupillae and ciliary muscle. So the pupilomotor fibers which lie in the superficial part of the nerve are supplied by pile blood vessels, while the main trunk of the nerve is supplied by vasa nervorum. Hence, vascular causes of third nerve palsy which affects the vasa nervorum are pupil sparing. So if there is a tumor, it can compress the pile blood vessels as well as it can compress the pupillary area of the third nerve. So hence, the cause due to diabetes, hypertension, all these things will affect the vasa nervorum. The vascular cause, it affects the vasa nervorum, and because of which what happens is the pupil is paired in the case of diabetes, hypertension. If the cause is tumor or trauma, what happens is the pile blood vessels are affected and that will the pupilomotor fibers will also be affected, and hence what happens is there will be pupil involvement in the case of trauma or tumor of third nerve palsy. This is the course, as you can see here. The third nerve it starts in the midbrain at the superior colliculi and then it goes through the red nucleus and then it's near the posterior communicating artery and through the cavernous sinus into the superior orbital fissure into the orbit. So causes of third nerve palsy include vascular causes such as hypertension, diabetes. I told you in these conditions there will be pupil sparing, trauma most common in children, tumors, aneurysm of posterior communicating artery very typical, that is isolated third nerve. Clinical features. So what are the problems that the patient will have? The patient will have ptosis due to involvement of levator palpebrae superioris. The eye is positioned down and out. Down because superior oblique is intact and out because lateral rectus is intact. Because superior oblique is supplied by fourth nerve and lateral rectus is supplied by sixth nerve. Fixed dilated pupil due to involvement of sphincter pupillae. So pupillary involvement, if it's there, then there will be fixed dilated pupil. Weakness of accommodation due to ciliary muscle involvement. So that will also be there. So as you can see in this patient, there is a right-sided third nerve palsy. First picture shows the total right ptosis. Then After averting the lid, there is right exotropia and depression in the primary position. In the C picture, you can see that abduction is normal, whereas adduction is defective in the place of D image, whereas E image elevation there is no effect, and depression there is little bit of limitation in depression. So the patient will have down and out. So that is how only superior oblique and lateral rectus will be intact.